Good evening, everyone. Welcome to today's webinar. I'm Francis Awina, as correctly introduced by Bruce. Today we'll be discussing about diagnostic spectrum of lupus and lupus anticoagulant. And lupus is one of the antiphospholipid antibodies. So we'll be looking this in the broad spectrum of it. That is antiphospholipid syndrome. So our discussion will concentrate much on antiphospholipid syndrome. For us to diagnose antiphospholipid syndrome, we don't rely on lupus anticoagulant alone. We look at other antiphospholipid antibodies, that is the beta-2 glycoprotein 1 and also the anticardiolipin. So we are going to look at it as an antiphospholipid syndrome. So lupus is just one of the players in antiphospholipid syndrome process because it is an antibody, that is antiphospholipid antibodies. One of the antiphospholipid antibodies that binds and initiate thrombotic events. So in this case, we'll see an hypercoagulable state where patients have got increased thrombosis rather than bleeding. And lupus anticoagulant is also one of the natural inhibitors in coagulation. So other natural inhibitors include antithrombin 3 and protein C, protein S. So lupus anticoagulant is one of them. But now lupus anticoagulant has a role in development of antiphospholipid syndrome, as we are going to see in the presentation. A common disease is mostly in patients with SLE and also in those patients who are suffering. That can also be secondary to HIV or hepatitis infection, and are also responsible for fetal losses. So we'll discuss more. Bruce, am I audible up to that point? You'd want to confirm before I start.
You're audible, but you're breaking.
Okay.
Yes, you're audible, but we've
You let me know if I'm not breaking. So the objectives of the today webinar is to describe the pathophysiology and the diagnosis of antiphospholipid syndrome. Yes, the topic is talking about the lupus anticoagulant, which is one of the antibodies in APS. So we can't talk about lupus anticoagulant without mentioning the antiphospholipid syndrome. So the whole presentation will revolve around antiphospholipid syndrome, and we are going to see the picture on how it emanates and some of the diagnosis and even the management. And the second objective will be to elaborate on various laboratory tests on APS and to highlight epidemiology, just to see what is the impact in terms of epidemiology and what population is mostly affected. And the third one, the fourth is to explain the treatment modalities. So we'll also look at how the treatment, mostly the regimens that are used here are anticoagulant therapy and maybe corticosteroids or immunosuppressive drugs such as cyclophosphamide can also be used. And these ones can be used in more serious events like in catastrophic antiphospholipid syndrome. And then finally, to sensitize laboratory professional on diagnostic of on diagnosis of APS. Yeah, so I know maybe some of the labs professionals have not come across this test, or maybe it's not common, or maybe if it is common, they are not doing it. So especially those ones in the sub-county setups. But these are things which are there. So through this webinar, you might be able to pick a case or one or two and then refer to the relevant facility where the test can be done to aid in diagnosis, especially in women who are, or the female of childbearing age that are having difficulty in pregnancy or difficulties with miscarriages. The miscarriages could be simply due to antiphospholipids antibodies. and lupus anticoagulant is one of them. So under the introduction, we have antiphospholipid syndrome. We want to see what is this antiphospholipid syndrome and how does it unfold. It is an autoimmune disorder, and this autoimmune disorder is characterized by arterial, venous, small vessel thrombosis, and recurrent early pregnancy loss, fetal loss, or pregnancy morbidity. So that's all about antiphospholipid syndrome. It is a syndrome that is characterized by formation of clots. So these clots could be in the small vessels like the capillaries, it could be in the venous, like in DVT cases, it could be on arterioles, and then you could also see recurrent early pregnancy loss, which is mostly due to the clots forming in the trophoblast or the placenta. So now the placenta is not able to function normally. So the fetus or the developing fetus will suffer ischemic damage. They are not able to receive nourishment or pregnancy morbidity. And not just that, because these conditions can also be seen, these clinical features can also be seen in other morbidities. So what will exclude or whatever will differentiate these cases is that in APS, there has to be a presence or rising levels of antiphospholipid antibodies. So when you are seeing arterial thrombosis, venous thrombosis, and or also microangiopathy, and then at the same time, in these patients, you are seeing a rise in antiphospholipid antibodies, that is lupus or anticardiolipin, then you know you are dealing with a case of antiphospholipid syndrome. So it can be primary. Primary, it means that there is no comorbidity. It is not secondary to any other condition. So that is now primary antiphospholipid syndrome. And mostly the primary cause is unknown, but it could be also associated to a mutation in one of the HLAs, HLA-DR7. It can also be secondary to other comorbidities such as systemic lupus erythematosus, that is SLE, it's the most common one, and then rheumatoid arthritis, and an autoimmune disorder, neoplasm, HIV, hepatitis A, B, and C. So the antibodies include lupus anticoagulants, anticardiolipin, and anti-beta-2 glycoprotein antibodies. So some of the clinical manifestations you are likely to see. Some of the clinical manifestations you are likely to see include livedo reticularis, and then cutaneous ulceration, thrombocytopenia, hemolytic anemia, valvular heart diseases, and nephropathy. So those are just some of the clinical manifestations of these particular disorders. So when it's come to epidemiology, in healthy individuals, about 1 to 5% will present with antiphospholipid antibodies. And in terms of incidence, in about 500, it's about 500 cases per 100,000 persons per year. Then 50% of antiphospholipid syndrome cases are not associated, which means 50% are those ones which are primary. They are not associated with another rheumatic disease. And 50% is due to secondary. It could be due to rheumatoid arthritis or SLE, just as we have described in the previous slide. And then antiphospholipid antibodies found in about 30 to 40% of patients who have SLE are likely to have antiphospholipid antibodies. Only that about 10% of them will progress to have antiphospholipid syndrome. So yes, about 30 to 40% of patients with SLE will tend to form these antibodies, but about 10% will progress to the disease state. So APS is also responsible for 14% of all the strokes. In most patients with stroke, you'll find that one of the causes is APS, antiphospholipid syndrome. Myocardial infarctions, about 11% of them. Deep venous thrombosis, 10% of such patients, and then 6% of pregnancy morbidity and 9% of pregnancy losses. So with that data, we can see that it has an impact and something that needs to be looked at. So the doctors really need to go into when they're taking history, they need to begin and rule out possibility of these particular patients developing antiphospholipid syndromes. So catastrophic antiphospholipid syndrome is one that rapidly progress. So it progresses from the primary antiphospholipid syndrome and with the widespread vascular occlusion. So this one involves different organs where the thrombosis is affecting more than one organ. So this is a multi-organ, and mostly the clotting is happening in the small vessels. That is the arterial lining the vessel. Arterial supplying these particular key organs, and also in the capillaries. So in few days with the mortality rate. So another thing is that 50% of it, the catastrophic APS have high mortality rate. So and about 50% of them dies. Then in terms of age, there is a female predominance specifically for secondary APS. And then age is more common in young to middle age in terms of population. So if you look at the pathophysiology of antiphospholipid syndrome, it's mediated by antiphospholipid antibodies. So what this one does is that they will bind to the beta-2 glycoproteins 1. So these beta-2 glycoproteins are found in almost all the cells, because if you remember the cell membrane. Cell membrane mostly is made up of phospholipids. So, and we have got beta-2 glycoproteins along the cell membrane. So this anti-beta-2 glycoprotein, it binds specifically to this beta-2 glycoprotein 1 receptors. And then once that one it does, it will activate platelets. So once platelets are activated, there will be adhesion and aggregations, resulting into a clot. And another thing, they're also able to, these antibodies will also initiate or rather activate coagulation cascade. And when it's come to the coagulation cascade, it sustains the thrombosis in a way that in a normal circumstances, what normally happen is we have got natural anticoagulants or rather proteins which once a clot has been formed in the normal hemostasis process, they remove the activated the activated clotting factor so that there is no continuation of clot formation. But now in antiphospholipid syndrome, what these antibodies does is that they will inhibit protein C. So once protein C is inhibited, they cannot remove. Protein C is the one that removes activated factor 5 and activated factor 8. So once there is inhibition to the protein C, what happens? It means that the activated factor 5 and 8 will continue with their activity. And so therefore the activity here means that the coagulation cascade continue and more clot formation. And as a result, we will be having a thrombosis. Protein S is also required for the activation, for activated protein C to function, because it is the cofactor, the one that stabilizes the activated protein C. And then we have got thrombomodulin and antithrombin 3. So that is what they does. They inhibit this particular antithrombin 3 is very important because it deactivates or rather inactivates so many activated factors. That is factor 9, factor 10, factor 11, and factor 12. All those are activated by antithrombin 3 in the normal hemostasis process. So, and in this antiphospholipid syndrome, that one is deactivated. And so that one is inhibited. So that means that there is formation of thrombosis in the system in this particular disease. So another thing that it does, it also binds to the binding of these antibodies will cause injury to the endothelial cells lining of the vessels. And so once that one is done, it will cause these particular injured cells to release things like Volvibrand factor, thromboxane A2. So those ones will activate even platelets or even recruit more neutrophils on the sites and also activate complement system. So that one will increase tissue factor activity, and the tissue factor is the one that activates the extrinsic pathway. So again, we are leading to another clot formation process, and also result into pro-inflammatory cytokines release. And the next one now is the pathology in pregnancy, where they bind to the placental tissues and decrease the trophoblastic cells growth and also increase the apoptosis of these particular cells. And so therefore it results into placental insufficiency and finally the fetal loss. So the other diagram on the right, just a presentation on how this happens, as you can see. So in this particular patients, they will have their B cells will be induced. And then once they are induced, they will be able to differentiate to give us activated, antiphospholipid antibodies. And then the antiphospholipid antibodies will bind the beta 2 glycoprotein ones on this membrane, on the cell membrane. And so once that one is done, we have got complement activation. Complement activation results into lysis of these particular cells and will expose the endothelial cell linings of these particular cells. Activation of monocytes, and monocytes will be able to release pro-inflammatory cytokines such as tumor necrotic alpha, and these ones are able to recruit more macrophages to the site that cause more injury and even clotting. And then we have got recruitment of polymorphonuclear cells like the neutrophils. These ones will result into trapping of the neutrophils, or rather aggregation of the neutrophils as part of the clot that is forming, mostly seen mostly in arterial cases where you are having arterial thrombosis. And then there will be increased activity of the tissue factor and also platelets. So as we have said, platelets that will be they'll be activated and there'll be aggregation and adhesion to each other. So the end result, you'll have inflammation, thrombosis, and fetal death in case that we are seeing that in a pregnancy situation. So what happens in the pregnancy is that there will be reactivity of the endothelial structures, which perturbs the balance between the prostaglandin E2 and the thromboxane secretions. So the platelet interaction resulting in the upregulation of platelets. So what it does, that thromboxane will increase the activation of platelets. And so therefore there will be platelet aggregation and the dysregulation of complement activation, and also abnormal interaction between the activated phospholipids and phosphatidyl serine exposed during the trophoblast. So just what happens at the trophoblast stage. So that is what happens. The antiphospholipid antibodies that are formed, they attack the trophoblast cells. And so once that one is done, they will activate platelets and then they aggregate and form clots. So those clots will block the vessels, the blood vessels that are lining the trophoblast, nourishing the trophoblast cells. And the placenta is rendered non-functional. So the growing fetus cannot receive nourishment. So this is just a schematic diagram of what we have discussed on the pathophysiology, where we are having the binding of the antiphospholipid antibodies to the endothelial cells and the platelets, and the platelets. So once that one binds to the beta 2 glycoproteins, there will be decreased protein C activation, and we saw what does that, what is the implication of that. So if there is a decreased protein C activation, it means that the activated factor 5 and 8 cannot be removed in the system. And so therefore the activity continue and more clot is formed in the system. And then antithrombin 3 activity also is decreased. And so therefore most of the several serine proteases, or rather coagulation factor that are activated, cannot be removed. And then annexin 5 binding, fibrinolysis, all this. Fibrinolysis is the one that is responsible in the dissolution of clots. So even the match clots that are that are formed in this particular case, the antibodies function in a way that they inhibit the tissue plasminogen activator. So this one cannot convert plasminogen to plasmin that will be able to degrade this particular, or rather dissolution of this particular clot, so that we have a fluid state. And then there will be increased activity of tissue factor pathway, then pro-inflammatory cytokines, as we had mentioned, the things like tumor necrotic alpha, And then if it is secondary, then it could be due to infection, trauma, and we have got, finally, you'll have a very big clot forming in the vessels, and that will be now the picture of antiphospholipid syndromes. And the antibodies that are responsible for this, as we have discussed, is the anticoagulant. That is antibodies towards the chydolipins. Chydolipins are mostly the membrane linings of mitochondria. The mitochondria are found in almost every single cell. So you can imagine if you're having anticoagulant in the body. So it means we'll be having these particular antibodies causing havoc in almost the entire system. So the clinical manifestations that you will see. So for thrombosis, we can have venous. Venous, mostly you'll see DVT, that is deep venous thrombosis. Then we'll have arterial. We will see this common in stroke cases. And then microvascular. Microvascular, that is the vessels endings, the arterioles and the venules, those ones, and even the capillary endings. So there will also be clot formations, and that is a common presentation in a catastrophic antiphospholipid syndrome. And so what you'll be able to see in the long run is something known as thrombotic microangiopathy. And this one we've said is responsible, has got about 50% mortality rate. Then we have got obstetric. Obstetric, you can have at least one fetal loss. Fetal loss, if it is greater than 10 weeks gestation, and there is a fetal loss, that is a sign of APS. But where there is spontaneous abortion in those ones that are less than 10 weeks gestation, 3 of them, so 3 early pregnancy loss, that is a characteristic of antiphospholipid syndrome. Or another one is a fetal loss, which are less than 34 weeks once, but this one can be associated with placental. If the investigations are done, the conclusions will be either preeclampsia or placental insufficiency. So you will rule out other correlating factors like hormonal status of the mother, and so on. So if at all those ones are correct and still we are having a fetal loss at that stage, then the doctor has to rule out antiphospholipid syndrome. And then we have got cutaneous. You will see on their skin livedoreticularis, that is fixed lattice skin pattern, or livedoid vasculopathy. So hematologic, if you do TBC, you'll be seeing a thrombocytopenia, and thrombocytopenia, mostly the platelets will range between 50 to 150,000. And also hemolytic anemia will be a feature in this case. So also valve thickening and vegetation for, I think that one, those ones I can avoid for now. Can move to the next. So I want you to get this slide clear, because this is what guide the diagnosis of antiphospholipid syndrome. And this one is guidance from the International Consensus Statement on Revised Criteria for Classification of Antiphospholipid Syndrome. So for you to conclude that a patient has antiphospholipid syndrome, at least one clinical and at least one laboratory criteria are met. So you cannot just make a decision based on the labs alone. So you have to correlate the lab findings and the clinical findings. So the clinical criteria, one is one or more clinical episodes of arterial, venous, or small venous thrombosis in any tissue or organ. And the important point to note there is that thrombosis must be confirmed by imaging or Doppler study. So you don't just assume that there is thrombosis. So you have to do a scan, Doppler, and then if there is one or more clinical episodes of that, then you could be dealing with a case of APS. And then pregnancy morbidity is another clinical criteria that you can use. So pregnancy morbidity, as we discussed earlier, one or more unexplained death of a morphologically normal fetus at or beyond the 10th week of gestation. Morphologically normal, which means there is nothing wrong with the development of the fetus. But now the loss is due to antiphospholipid antibodies. So these antibodies are causing what? They are causing clots in the along the placental linings. So therefore making the blockage. So it means that nutrients cannot reach the developing baby. And then one or more premature birth of a morphologically normal neonate at, on, or before the 34-week of gestation due to preeclampsia, eclampsia, or placental insufficiency. So you rule out other causes. So if the causes is due to the listed above, that is preeclampsia, eclampsia, or placental insufficiency, then that's pointing towards APS. And then 3 or more unexplained consecutive spontaneous abortions, if at all they are less than 10 weeks gestation of age. So these are the clinical criteria that are used. And we have said that for a conclusion to be made, at least one clinical criteria has to be met and at least one laboratory criteria. So the lab criteria, anticoagulant of IgG and IgM isotype can be done. So if the concentration is greater than 40, then that one is in an indication of a possible positive case of APS. And then also you can do lupus, not you can do, but we do the 3, antiphospholipid syndrome. You do the anticoagulant, lupus, and anti-beta-2 glycoprotein 1. And when you are doing this, in a positive case, you can either have one of the antibodies being positive or triple positive, which means the 3 of them. So where there is the 3 of them are positive, those patients have got highest risk of developing thrombosis. Unlike cases where only one antibody is positive. So the second one is lupus anticoagulant in serum. So this one, we used phospholipid-based coagulation test like APTT. So there will be a prolonged phospholipid-dependent coagulation demonstrated on a screening test. So first you start with the screening test, which means the patient have gone for PT and APTT. And then when doing this test, they are prolonged, especially the APTT. And now when we go for more specific tests like DRVVT, still it is elevated. But before we can go that, we must ensure that the prolongation that we are seeing is not due to an inhibitor. So you have to rule out that first before we can conclude it is lupus. So maybe you do a mixed study, not you need to do a mixed study and just to rule out that. Then now when you see even with the mixed study, then it is not factor deficiency. Now it is an inhibitor, which lupus is one of them. So failure to correct the prolonged coagulation by mixing with the normal. So that's the mixed study. You just do that one to rule out factor deficiency because the prolonged PTT could be due to factor deficiency, and especially factors that are involved in common pathway and those one in the intrinsic pathway. And then shortening stroke correction of the prolonged coagulation times by adding excessive phospholipid. So when you add excessive phospholipid and you realize that it has corrected or it has shortened, then that has an indication of what? Lupus, because the excessive phospholipid will mask the presence of lupus. This one we'll discuss more when you're looking at the laboratory tests to confirm lupus anticoagulant in the slides that are coming. And then finally, exclusion of other coagulopathies. So it is very important that you exclude other coagulopathies like factor 8 inhibitor or heparin. And then number 3 is anti-beta-2 glycoprotein 1 antibodies. So this could be IgG or IgM isotype in serum or plasma. So these are done the anticoagulant and anti-beta-2 glycoprotein. So use ELISA to do that. And something that is important, if it is positive, you have to repeat the test within a span of 12 weeks. Within a span of 12 weeks. So classification should be avoided if less than 12 weeks. So that test should be repeated after 12 weeks. If a patient comes today, they have done lupus anticoagulant, it is positive, you need to do a repeat after 12 weeks for you to conclude that the patient is positive for that test. So what is lupus anticoagulant? It is a polyclonal immunoglobulin G, M, and IgA types, where antiphospholipid antibodies and as such interferes with coagulation testing. So it interferes with coagulation testing in that it will bind to the phospholipid protein complexes, therefore prolonging the clotting time. if you look at your intrinsic pathway, if you need if you look at your if you look at your intrinsic pathway and the common pathway, know that once factor 10 is activated, it needs calcium, phospholipid, platelets, and factor 5 and factor 5 activated. Then they form the complex, which is the factor 5 complex. So factor 5 complex is the prothrombin activator, the one that now activates prothrombin to thrombin. So what happens now, if a patient is having lupus anticoagulant in their system, it is an antiphospholipid antibodies. So it will, but because we said in APTT or phospholipid-based test, the reagents that we use already has, like in APTT, they have phospholipid and a contact factor, things like kaolin, as part of the ingredient that forms these particular reagents. And then later we had calcium. That is now the normal APTT. But now for this one, if there is an inhibitor, what happens? It means that the lupus will bind the phospholipid in this particular reagents. So once it binds the phospholipid, that reagent will not be able to convert prothrombin to thrombin, that later convert fibrinogen to fibrin to form a clot. So you'll be seeing a very prolonged time, which means APTT will be giving you very high time in terms of seconds. So commonly found in asymptomatic elderly individuals. So you maybe elderly individuals and those with autoimmune disorders. So it can be found in asymptomatic, those ones which are not experiencing any signs, and also the ones with autoimmune disorders like systematic lupus erythematosus or even rheumatoid arthritis. So more specific for thrombosis and other clinical complication of antiphospholipid syndrome, as we had seen in the pathophysiology, and then it can be the most common acquired cause of thrombosis if it is secondary for the patients who are already having other underlying conditions. And then patients do not bleed, but other problems can occur concurrently. That, yes, we said in this particular presentation, in APS, what we are seeing is the thrombosis. There is not really bleeding because remember the coagulation factors are normal. But bleedings can occur in cases where there is thrombocytopenia. Those ones can cause bleeding. And then we are seeing isolated deficiency of prothrombin. If that is the case, then you might see bleeding even in this particular patients. And those ones with qualitative platelet defects, which means the platelets is not functioning normally. Yes, they are sufficient in number, but they are not able to bind to the von Willebrand factor, or rather aggregate or adhesion is not happening as required. Then you are likely to observe a bleeding. Or also bleeding can be seen in recurrent spontaneous abortion cases. So lupus anticoagulant is often identified during routine screening with the standard APTT. That is activated partial thromboplastin time test based on the sensitivity of the reagents. So in vitro, what we will see in the lab is the prolonged APTT. But now in vivo, the clinical picture in the patient is thrombosis rather than the clinical bleeding. And in the pathophysiology, we had seen how these antibodies activates platelets. They result into pro-inflammatory cytokines and also activation of complements. And these ones will result into aggregation of platelets and clot formation and even activation of the coagulation cascade. So the antibody may be persistent or transient. Now let's look at the diagnostic spectrum for lupus anticoagulant. So the first step is the prolongation of at least one phospholipid-dependent test. And then now once there is a prolongation, you need to give an evidence that inhibitory activity depend on the what? On the phospholipid and not other interfering factors. So lupus anticoagulant must be carefully distinguished from other inhibitors, which may give similar results. For example, the cases of antithrombin 3 deficiencies and all that. So we rule out that. And then at least 2 different screening assays should be negative. So presence of lupus anticoagulant must be confirmed after at least 12 weeks or preferably after 1 year. So if it is positive, then you don't conclude with that one positive. You repeat the test after 12 weeks. And we also remember, you don't just rely on the lab results alone to conclude that a patient has antiphospholipid syndrome. So you have to correlate the two. That is, at least one clinical criteria has to be met, and also one laboratory criteria has to be met, as we had discussed. So in terms of testing in the lab, we have got sensitive versus insensitive reagents. So sensitive reagents are those ones with low phospholipid concentration. And also how the pre-analytical is very key when you are doing this particular test. You ensure that the citrated plasma you are using is platelet poor as possible. So if you just get a sample, for example, and then you centrifuge for 5 minutes, maybe at 2000 revolution per minute, you'll not be able to achieve that. So at least you should centrifuge for 10 minutes at 4000. And when you do that, you'll be able to achieve a platelet poor plasma. Even if you test that citrated plasma in your TBC machine, you'll realize the platelets will be reading less than 10. So you need to have a platelet poor plasma as possible, even if it means spinning it twice to give you that platelet poor plasma. Because remember, platelets are also phospholipid in nature. And in the first step, we are using a sensitive reagent, and we need to have minimal concentration of phospholipid as much as possible. So the APTT reagent will vary in sensitivity based on the type and the concentration of phospholipid. So the insensitive APTT reagent are those ones with high concentration of phospholipid. So that's the one we are using for confirmation now, just to be sure that it is due to phospholipid and not any other inhibitor. So lupus anticoagulant present itself as antibody to phospholipid in the laboratory, and a reagent that is low in phospholipid is sensitive to the antibody, just as we have discussed, and will result in a prolonged screening test. While that insensitive reagent is high in phospholipids and will mask the presence of lupus anticoagulants, resulting in a short or rather normal APTT. So what you will see when you are testing it in the lab is that the screening will give you a prolonged APTT. And then now in the screening, we say you use a reagent with low concentration of phospholipid. And then the insensitive one, for the confirmatory, it will have high concentration of phospholipid. So now when you are doing the second test, the second APTT test using a high phospholipid reagent, what will happen? You'll see a shortened time test, shortened results compared to whatever you received at first. So sample for lupus anticoagulant testing must be platelet poor. These ones we have explained. And the presence of platelet falsely shorten and mask the results. So the test that we commonly use in the lab to do this is dilute Russell Viper venom test, that is DRVVT. So based on the activation, so what this one does is that the Russell Viper venom will activate factor 10 direct. And the importance of that is that the test will not be affected by deficiency or inhibitors to factor 8, factor 9, factor 11, or 12. So in DRVVT, we have skipped the intrinsic pathway because the reagent that we are using, the Russell Viper venom, just goes direct to the common pathway and activates the factor 10. So when lupus anticoagulant is present, it will bind the phospholipid and inhibit the thrombin generation, therefore prolonging the clotting time in the screening phase. So the test will be performed in two steps. One is the screen, as we have explained. that what happened there, the DRVVT screening step will use a reagent with a low concentration of phospholipid that in the presence of lupus will cause a prolonged test. And then now in the confirmed step, we are using a reagent with high concentration. So masking simply means that the lupus anticoagulant that is present in the plasma of this particular patient would have bind much of the phospholipid, but because we are having the phospholipid in excess concentration, the remaining unbound phospholipids will be able to form a complex with factor 10, and then what happens? Give us the factor 5 complex. And then now the factor 5 complex will activate prothrombin to thrombin, and then fibrinogen to fibrin, and then finally we have a clot. So that will be more of a corrected or will be being a shortened or a normal APTT when we are in the screening phase. So for you to confirm that now there is a presence of lupus anticoagulant, you do a ratio of the screen to confirm. And if the ratio is greater than 1.2, the result is positive for lupus anticoagulant. So if you are not using the DRVVT, you can also use hexagonal phase neutralization. But this hexagonal phase neutralization, what is it? It recognizes hexagonal phase phosphatidyl ethanolamine, but not those phospholipids that results in a bilayer. So it is another reagent. So you'll also do two. Instead of the screen and the confirm, here you'll be using a reagent that has got HPPP and those ones without APP. And then you get the difference between the two tests. If the difference is greater than 8 seconds, then the result is considered to be positive for lupus anticoagulant. So in management of antiphospholipid syndrome, the treatment regimens must be according to so here you do it based on the clinical condition of the patient and also the history of the thrombotic events. Where if these patients are asymptomatic, they are not having any symptoms, but they're having positive blood tests, you don't need any specific treatment. So there is no specific treatment that is given. However, if maybe they are female and they are pregnant, you give them a prophylactic therapy to eliminate the risk factors. So things like oral contraceptives, those ones you eliminate, smoking, hypertension or hyperlipidemia. And then prophylaxis is needed during surgery or hospitalization, as well as any associated autoimmune disease. If at all they are having autoimmune disease, then also put them on a prophylaxis treatment. So low-dose aspirin is used widely in aspirin is an antiplatelet agent. It's normally inhibits cyclooxygenases. So, however, the effectiveness of low-dose aspirin as primary prevention for APS will remains unproven. And then in patients with SLE, you consider hydroxychloroquine, which may be intrinsic anti-thrombotic properties. So those are some of the therapeutic regimens that are used in patients with APS. So in case where there is thrombosis, there is actual thrombosis. We even confirmed with the Doppler. There's either arterial or venous thrombosis. Full anticoagulations with intravenous or subcutaneous heparin followed by warfarin is given. And then our target, if they're told they are on oral anticoagulants, the target for INR will be 2 to 3 for venous and arterial thrombosis. But if these patients are having recurrent thrombotic events, then the INR range is between 3 to 4. Then severe or refractory cases, you give a combination of warfarin as well as aspirin. So another thing to note, just a minute. So treatment for significant recurrent thrombotic events in patients with APS is generally lifelong. So if at all they are experiencing repeated episodes of thrombotic events, then the treatment period will be prolonged. So in pregnancy, if there is positive antiphospholipid antibodies from the lab test, as we have seen, either lupus is present, antioxidolipin or anti-beta 2 glycoprotein 1 is present, there's no therapy, but still they can be given low-dose aspirin. And if there's a single pregnancy loss, then you give low-dose aspirin, or you just observe, or you put them on prophylactic treatment. And then where there's recurrent pregnancy loss, less than 10 weeks, or fetal loss greater than 10 weeks, plus no history of thrombosis, again, those ones you put on low-dose aspirin plus prophylactic dose of heparin. Recurrent pregnancy loss, less than 10 weeks or fetal loss, but now there's history of thrombosis, you put them on low-dose aspirin and the therapeutic dosage of heparin, and then after that, you switch to oral anticoagulants, such as warfarin, after they have delivered or postpartum. So in case where it is progressing, and now we are seeing the most severe form of antiphospholipid syndrome, that is catastrophic antiphospholipid syndrome, you will give hospitalization. The patient has to be admitted, and also the anticoagulation therapy such as unfractionated heparin are considered in that case. You can also do plasmapheresis just to remove the irregular antibodies in the system. And you can also give IV immunoglobulins that will wipe out these antiphospholipid antibodies. And of course, corticosteroids and immunosuppressive such as cyclophosphamide. And this one mostly given in cases where these patients are also having SLE, and at the same time, they are having antiphospholipid syndrome. So for surgical care, recurrent DVT may need an inferior cover filter, then a cover filter, and then if warfarin therapy is instituted, you instruct the patient to avoid excessive consumption of foods that contain vitamin K. Then activities, no specific limitation according to the clinic, but they should avoid sports with excessive contact if taking warfarin, limit activity in patients with DVT, and instruct the patient to avoid prolonged immobilization. So this diagram just kind of summarizes the algorithm that you use in the treatment of catastrophic antiphospholipid syndrome. So one is anticoagulation. The preferred in case of this severe case, you give unfractionated heparin and corticosteroids. And remember, unfractionated heparin requires very short duration of monitoring. You monitor with the PTT 4 to 6 hours apart. So you will assess and then treat precipitating factors. That is, if at all they are having other comorbidities like infection, malignancy, etc. And if the patient is also having systemic lupus erythematosus like SLE. So one, if it is SLE, you will ask yourself, if it is yes, then you give the patient cyclophosphamide. And then if they are on cyclophosphamide and there is organ threatening, if it is yes, you do plasma exchange. So if you do a plasma exchange, you'll ask yourself if there is a clinical improvement. If there's a clinical improvement, you consider immunosuppressive drugs and switch to oral anticoagulants. However, if there is no clinical improvement, you consider another drug, that is rituximab. These are some of the anticoagulant drugs that you can use. So in this other case, where the patient is having an SLE and there is no history of SLE, yes, they are having CAPS, that is the catastrophic antiphospholipid syndrome, but they don't have SLE. You just check if there is organ threatening, which means there is clot formation in more than 3 organs. So if there is organ threatening, if it is yes, again, you will do plasma exchange. If there is no clinical improvement, you discharge them on oral anticoagulants, and you also put them on immunosuppressive drugs. And where there is no organ threatening, and there is clinical improvement, you do clinical improvement, yes, we do the same. You give immunosuppressive and switch to oral anticoagulants. And if there is no clinical improvement, Then you do plasma exchange. And then after plasma exchange, you assess, is there clinical improvement or not, just as we have discussed for the rest. So another thing that is important, you also need to exclude other microangiopathic syndromes, then intravenous. So you need to exclude that. So we've been talking about the clinical presentation. That is how it happens. So that is the levodoreticularis on the skin. So the picture that you are likely to see in this patient with antiphospholipid syndromes. So in skin disorders, you will see lividoreticularis. It is the most common. Then splinter hemorrhages, could be leg ulcer or superficial thrombophlebitis. Neurological defects include migraine headaches, seizure, and dementia. Then cardiac abnormalities, we have myocardial infarction and cardiac valve vegetation. So at least we've seen, in the presentation, we've seen the diagnostic spectrum of lupus anticoagulant, where we are using the DRVVT. It has got two phases. The screen phase, you are using a low concentration phospholipid reagent, and this confirmed phase where you're using a high concentration phospholipid reagent. For us in the lab, that's where we take part of the major role, and then you will do as a ratio of the two. If the ratio of screen to confirm is greater than 1.2, it is a confirmed case. And remember, it's not just one antibody that you are looking for. So you also have to correlate that report with anti-cardiolipin results, and also anti-beta-2 glycoprotein 1 antibody result. And then another important thing, all these three need to, and if any is positive or all of them are positive, you need to repeat the test after 12 weeks. And then another take-home message is that for us to conclude that a patient has got antiphospholipid syndrome, what do we do? There will be at least one clinical criteria and at least one laboratory criteria. So the clinical criteria is in terms of the thrombosis. You exclude the venous and the arterial thrombosis. So you do Doppler to rule out that. And then the second one is in the pregnancy for the expectant ladies. So pregnancy, you look at whether there are spontaneous abortion for those ones which have got less than 10 weeks, gestation, 3 of them. And also the ones which are greater than 10 weeks, at least one fetal loss. And also another one fetal loss, which is greater than or rather less than 34 weeks. And when the investigation is done, that one can be attributed to placental insufficiency or preeclampsia. And that marks the end of our presentation for today. Over to you, Bruce.
Thank you so much, Francis, for the nice presentation. Indeed, it's an eye-opener for most of us who are not very familiar with this area. I can see Kezia Mungara is saying, nice presentation. Is it possible to get photos of dark skin? Oh, this is already a question. Maureen Joki is saying, good presentation. In Kipchumba, nice presentation. Florence Akoth, nice presentation. Francis Musioka Kitetu, nice presentation. Samuel Sigei, excellent, thank you, very insightful. Okay, Elvis, excellent presentation, educative and informative. Yeah, so generally it's a good presentation. We thank you, Francis. I don't know whether from your end, are you able to see any question in the Q&A? Or before you go to the Q&A on your end, maybe I can read the one on my end. Wilfred Morias is asking, most facilities lack these means of testing. Has the government set specific hospitals As the government sets specific hospitals which deal with cases regionally or referral hospitals, do such people who suffer from SLE form a given group to trace their progress? Over to you, Francis. Have you had the question?
Yes, I've had the question, and for the government, I can't really speak much for the government, and I don't know the status of things at the national level when it's come to antiphospholipid syndrome testing. In my mind, I was even wondering how they isolate these cases, especially in the villages, or maybe mothers are losing pregnancy that could be avoided. But maybe due to lack of thorough investigation, proper treatment is not given. It's something that really needs to be looked at the national level. And I'm also not aware whether KNH does this particular testing. But as at the Nairobi Hospital, in case you have a patient like that, you can always refer them at the Nairobi Hospital. We do this test and we'll give you result within a week. You will have your result. We do the anticoagulant, we do the anti-beta-2 glycoprotein, as well as lupus anticoagulant.
Thank you so much.
And we also do the Doppler ultrasound for the radiology.
Thank you so much. Stella Nyamboga is saying, excellent, my first time to learn about this. Okay. Arnold Simiyu is asking, is it a genetical disorder and is it inheritable? Over to you, Francis.
Not really inheritable. It can be, okay, the cause is not known as such, but because of HLA, for HLA, okay, there we can leave it open for discussion because again, we said a mutation in HLA-DR could induce, but other immunosuppressive diseases like HIV, hepatitis can be predisposed. They can induce the formation of this particular antibodies in the system. So it can be secondary to autoimmune disorders, that is SLE, rheumatoid arthritis, and the such. And it can also be secondary to HIV and hepatitis.
Thank you so much. Francis Musioka, any risk factors associated with LA?
So the risk factor associated with lupus anticoagulant now is the clot formation in the body. So that is the major risk factor. And we know clot is a silent killer. And then another thing, for the female, another risk factor is loss of pregnancy. Because once you have the lupus anticoagulant, chances of losing pregnancy, and we've seen now the episodes, it covers actually there is early loss of pregnancy, which present as spontaneous abortion. And there is also at least one fetal loss after 10 weeks. And also another fetal loss at 34 weeks is a big baby. Almost that's somebody that can be born and survive without even going to nursery. Yeah, so there is really a huge risk factor if someone is having lupus anticoagulant antibodies in their system. Next
Thank
question.
you so much. Okay, another question from Rugut Philemon Kipiego. How common is this condition? Is there a way you can correlate with the CBC?
CBC, we said in most cases, you are likely to see anemia where there's hemolytic anemia. Of course, you know how the hemolytic anemia is coming about because these are anticoagulant, antiphospholipid. So they are attacking the cells. So these cells that are attacked are being sequestrated or are rather destroyed at the spleen. So again, if you look at the PVF, you are likely to see spherocytes. as an indication of hemolytic anemia, or maybe they might be absent. So another thing is that where there is thrombocytopenia, you'll be able to see. And we have seen the platelet range in the CBC will be between 50 to 150,000 in these cases. Is there a part that I've not answered on that?
Thank you so much, Francis. Another question from David Barimo. Which population is at risk? Or which population is mostly at risk?
The population of patients at risk are those ones which are suffering from autoimmune disorders. They're the ones who are most likely to form lupus, the antiphospholipid antibodies in their system. So they are at more risk. Then in terms of gender, the females are at more risk compared to the male. Because again, we've seen pregnancy can also, it could be one of the pregnancy morbidities.
Thank you so much. Another question from Kezia Mungara. Can it be drug-induced?
Drug-induced, yes. Though I don't have a particular drug for this case, but also the ones who are receiving chemotherapy, those are having malignancy, they are also at risk of developing lupus anticoagulant. Lupus anticoagulant and other antiphospholipid antibodies. It can be drug-induced.
Thank you so much. Okay. Eric Moridi is asking, what is INR? Over to you, Francis.
INR is international normalized ratio, and this one come about, remember we are doing prothrombin time test. So, and in prothrombin time test, we are using thromboplastin reagent. So thromboplastin reagent, depending on the harvest and different manufacturers, how they harvest their, and the source where they get their thromboplastin reagent. So if we just use the time, there will be a lot of variability in terms of time, because again, there will be a lot of variability. So to avoid that variability, the international community came up, the World Health Organization came up with international normalized ratio. That is, if you are manufacturing any reagent for prothrombin time test, you must come up with an ISI, that is International Standardized Index. So this International Standardized Index is what you program every time you receive a prothrombin time reagent in your lab. And you must enter the new ISI in your machine so that you get the right reading. So how do you come up with the international normalized ratio? The international normalized ratio, it will be the result of the patient. You divide by the mean normal plasma, and then you raise that to the ISI. So once you do that, you get the international normalized ratio. So where do we use this? We use it in monitoring of patients on oral anticoagulants. That is warfarin. That's where INI play a key role. So if a patient is on oral anticoagulants, their INR, normal INR is between 2 to 3. But for any normal population, they are not on any anticoagulation, less than 1. I hope that one is comprehensive for that. Yes, Bruce?
Thank you so much. Another question from Lillian Ouma. Lillian is asking, why is it LA common in pregnant women who miscarry a lot? What's the connection?
Yeah, so just as we had said, LA is one of the antiphospholipid antibodies responsible for these particular miscarriages. So that's why we say if we see this particular, that particular history, and you see maybe these patients are losing pregnancy at early stages, especially our early stages ndo niko concerned nayo sana, because mtu anaweza assume tu is normal, unaona, and then they move on with the life. then they end up missing a very key step there, because at that point they need to do a lupus anticoagulant test, the anti-cadolipin and the anti-beta 2 glycoprotein 1. Then from there they'll be put on treatment that at least will allow them to carry the pregnancy. And the correlation we have seen in the pathology, if this lupus anticoagulant is present in the system, it will attack the cells lining the placenta, the trophoblast. And the trophoblasts are the one responsible for the development of the placenta. And we know placenta plays a very key role for the development of the fetus. So if this one is interrupted, then it means the fetus will suffer ischemic damage and they will eventually die. And another thing, those antibodies will also initiate or rather induce production of pro-inflammatory cytokines, things like tumor necrotic alphas. And this one will increase the expression of oxytocin receptors that will induce false labor in them and will end up expelling the growing baby out. Yeah.
Thank you so much, Francis. That was a great explanation on INR from, that's a comment from Wilfred Gatua. A great explanation on INR. Thank you so much, Francis, for that. Gladys Kariri is saying it's nice and complex. She's also asking, is LA same as lupus erythematosus syndrome?
Systemic lupus erythematosus syndrome, or rather disease, is an autoimmune. It's also a systematic autoimmune disorder, and we say that 30 to 40% of these patients with SLE, they will develop they will develop the antiphospholipid antibodies. Yes, you are likely to find lupus anticoagulant in their system. In about 30 to 40, that's a big proportion of them, but only 10% are likely to progress to the disease state. That is for actually finally having the antiphospholipid syndrome as a disease state. If someone is asking whether multiple myeloma disease is SLE, multiple myeloma is a plasma neoplasm disorder. Yes, so here these are more of it affects the plasma cells. It affects the plasma cells. It is the plasma cells that will differentiate into antibodies. Yeah, so there you will be this disease mostly affect the development of the antibodies. So mostly in these patients you are likely to find light chains, things like the kappa and the lambda, if you do electrophoresis. And also you can do Bence-Jones protein, that one in urine. But yes, it is a predisposing factor. They are also likely to develop as a secondary APS. Like this, they can develop antiphospholipid antibodies and finally have antiphospholipid syndrome in their system. So someone is asking, which other components are positive for lupus for initial patient testing before APS anticoagulants are done? So normally, initially, they will just do the normal. You can also pick this from the routine testing, routine coagulation testing in the lab. That is, a patient is testing for PTINR stroke APTT. And then you are getting abnormal results, especially in both. Yes, because if it is in one, you can easily exclude. If it is APTT that is prolonged, then you know your problem is on the intrinsic pathway. So therefore, you will look for factors deficiencies, and the factors you are looking for there is factor 8 and factor 8, factor 9, factor 11, and factor 12. If it is just PT or INR that is elevated, yeah, we're talking about the PT that is elevated, then now you are assessing the extrinsic pathway. So therefore, there is pointing to factor 7. But now you are having both of them elevated. If you are having both of them elevated, you need to know why. You need to progress. You can't just conclude and stop there. So this is a routine coagulation testing. So it means the problem is in the common pathway, and most likely it is either the factor deficiencies in the common pathway or an inhibitor that is present. So for you to rule out the presence of an inhibitor, that's now where the mixed study comes in. So in mixed study, you will take equal proportion of the normal plasma and that of the patient plasma. So this normal plasma you don't just take for one patient, because in your lab you've done maybe several APTT and PT, and those ones with the normal result. So you pool. So once you pull this plasma, you take 50 microliter of this equal proportion and 50 microliter of the patient, the patient who is having both prolonged. And then once you mixed that, you will use your new sample, the mixed one, for to repeat the test. So if it is, and now you will concentrate more on APTT for this lupus because it is phospholipid dependent. If it is corrected, then you know it is not inhibitor, it is a factor deficiency. So you will explore the fact there, you will explore the testing for factor assays for that particular patient. But if it is still prolonged even with that, because the normal plasma is meant to provide the missing factor in the patient. So if it is still prolonged, then you are having an inhibitor. So then that's now you do a lupus anticoagulant testing. Now the DRVVT, and you also do the anticardiolipin and antiphospholipid. So mostly the APTT and PT will be prolonged in this particular patient. So next question, Bruce.
Thank you, Francis. Dr. Tom Were is saying, excellent CPD presentation. I teach this for my med students, hematology blood transfusion course year 3. Collaborative care between doctors and lab critical for good outcomes in APS. In resource limited rural settings, the clinical representations and CBC, that is thrombocytopenia, helps in guiding referral facilities that test the APS antibodies. Thank you so much, Daktari, for the comment. Okay. Hello, Francis.
Hello, Bruce.
Do you have any questions from your end? Because my Q&A seems exhausted. A few comments here and there from Dr. Were, Tom. He's saying excellent
so
CPD presentation. Hello?
Thank you so much. Thank you so much, Dr. Were, for the compliment.
Yes.
So another thing, somebody was asking, yes, I would advocate if a patient, a patient or a female of childbearing age, they are having history of losing pregnancy. It is very important that they do this test, yes, to rule out. And at least we've seen in the clinical criteria. So from the history, the doctor is able to pick. And it is also very important that the doctor exclude other possible causes of losing pregnancy. It could be due to hormonal imbalance, it could be due to congenital abnormalities, things like that are excluded. So once this one is excluded, even the scan is showing that the fetus is the developing fetus is morphologically normal, and the mother doesn't see and the mother doesn't seem to be having even problem with their hormones, then now the doctor has to do antiphospholipid syndrome test, because that could be a typical case of APS that is developing. So it is very important, for patients with history of losing of miscarriages. I agree that test need to be done for them. I think that. I don't know if there's any other that we've left out.
Thank you so much. Seems no any other question. But from the comment section, I can see a lot of compliments for this presentation. Lawrence Okonda, from the explanation, it is important to do anti-cardiolipin antibody tests for proper management. Thank you so much, Lawrence, for the for that. John Otieno, good presentation. Can you WhatsApp me or email me? Maybe you need to specify, John. Do you want the presenter to WhatsApp you? You can give us your phone number so that he can be able to email you or WhatsApp you. Thank you so much, John. Good job, Christopher Mugambi. Okay, Patricia Mutizo is asking, at what cost? Maybe, I don't know which service is this that Patricia Mutizo is asking the cost. Patricia, you need to be clear on what service. Okay. So thank you so much. At this particular point, I want to say that we are coming to the end of our today's presentation. I want to also announce to you that this presentation or this webinar will attract 3 CPD points that will be accredited to your ChemHTB portal within 24 hours from now. I want to also announce that LMSK, if you are a member, we are organizing for a dinner that will come on 28th of November at Bridin Westlands Hotel. You are mostly welcome. For non-members, you can register to be a member. You can, but you're also very much welcomed. There is a circular going around. You can register and comply by paying 3,500 for the dinner if you are a non-member. But for members, it's a free dinner for us. The dinner will be starting from 6 p.m. till midnight, and you're all much welcomed. So at this particular point, I want to ask our speaker, Francis. Francis, your closing remarks before we end this webinar today.
I just want to thank everyone for attending this particular webinar, and really an eye-opening, especially for patients with history of miscarriages, because I know my worry is not even the ones who can access this service. My worry is especially those ones in the villages where we are coming for the homes, in the sub-counties there. Do they even know? Because most of the time I know they'll be doing other treatment, and maybe it is just a lupus antiphospholipid antibodies that is responsible for those particular miscarriages. And if this one is handled correctly, they can actually be treated and then be able to carry the child to term. They could be able to carry the fetus to term. So in terms of testing, yes, we are not just talking about lupus anticoagulant alone. So in terms of testing, it's good you do the 3 of them: anti-cardiolipin, anti-beta-2, glycoprotein 1, and then lupus anticoagulant. Those 3 join together. And then once you do that, you correlate with the clinical criteria. So the clinical criteria are in terms of thrombosis and also in terms of the pregnancy. So if it is a female of childbearing age, you consider that. And according to the international guideline, at least 1 lab criteria has to be there, and at least one clinical criteria has to be there. Then it qualifies as APS. Then now they can see the doctors to be put on prophylactic treatment or maybe management of thrombosis. They can be put on various anticoagulant therapy. So having said that, thank you everyone for listening to me, and may you all have a good evening.
Thank you so much, Francis. Let me respond to a few questions here. Samuel Sige is asking, how do you become a member of LMSK? For Francis, you can visit our website, which is www.lmsk.co.ke, where you'll be guided so that you can become a member. Alternatively, you can there's a mobile number you can call. It's just online, 0737. You can call it and you'll be guided appropriately. Patrick Mashero is asking, will be the dinner, will dinner be done via Zoom? Patrick, dinner, you come, we dine, we dance, we listen to a few talks, so it will be physical. It will be at Prydain Westlands Hotel. So with that, I want to say thank you for coming and attending this important webinar. We are coming to the end of it, and I want to say thank you so much, Francis, for that educative presentation, and may God bless you. So see you guys on Wednesday for another webinar from 3 p.m. Thank you so much.
Thanks so much, Bruce. Someone was having the cost of antiphospholipid syndrome testing. Unfortunately, I don't have it in mind, but what you can do, you can always contact our hospital. At the Nairobi hospital, will be told what is the cost for the antiphospholipid syndrome. So it is like that, and it has those 3 antibodies, the lupus, anticardiolipin, and anti-beta-2 glycoprotein. Thank you.